Hi there, and welcome to this video learning series. My name is Lara Okoloko, and I'm a provider educator with the University of Washington's Addictions, Drug, and Alcohol Institute, where I support professionals like you working in behavioral health and substance use treatment. I'm also a clinical social worker with experience in both direct practice and teaching, and I've worked with interdisciplinary teams helping people and their families navigate substance use and mental health challenges. In this video, we're going to talk about seeing and interacting with trauma. Let's get started. Let's start with a basic definition of trauma. SAMHSA, the Substance Abuse and Mental Health Services Administration, defines it this way. An individual trauma results from an event, a series of events, or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, we all experience situations that are frightening, stressful, or even harmful, but not all of those situations are traumatic. Things become traumatic when the event overwhelms our coping skills. And this is pretty common. Over 70% of people worldwide have experienced a traumatic event, and 30% of all people are exposed to 4 or more traumatic events in their lifetime. In today's video, we're going to cover a few main ideas about working with trauma. Let's start with our first big idea. We can assume most people have experienced trauma. As we go through the key points in this video, you'll build a stronger foundation for practicing in a trauma-informed way, so you can show up with more understanding, care, and confidence with your patients. For some people, the initial symptoms that develop after a traumatic event don't go away on their own. There are a few risk factors for these symptoms developing into post-traumatic stress disorder. Post-traumatic stress disorder is a collection of symptoms that don't resolve on their own. Let's take a look at some of the risk factors for developing PTSD, and then we'll dive deeper into the symptoms of the disorder. One risk factor for the development of PTSD is the severity of trauma. Another risk factor is repeated traumas. As we just learned, many people experience more than one trauma in their lifetime. For many, trauma was not just a single event in an otherwise safe and happy life. Think about child abuse, for example. Children in abusive homes may have experienced dozens or hundreds of events that most people would consider traumatic. For people who have a substance use disorder or another mental health disorder, this may increase the chance of developing PTSD after a traumatic event. This increases people's vulnerability. Another risk factor is avoidance. It might seem like it would make sense to avoid people and places that remind you of a traumatic event. Sometimes after trauma, people might find themselves avoiding going to a crowded place or driving in a car or listening to music or looking at photos that bring up difficult memories. They might not even want to leave their home anymore. But avoidance can actually make things worse. Avoidance tends to actually increase anxiety and worries and leads to more avoidance. People might find that their life is becoming smaller and a smaller circle of people and activities while their fears are getting bigger and bigger. In fact, most treatments for PTSD include facing the things that you're avoiding. This is called supportive exposure. A trained trauma therapist will help a survivor of trauma expose themselves to triggering people, places, and things as a main ingredient in most trauma treatments. This is not something you want to do yourself if you're not trained to do it. But with the help of a qualified therapist, this is one of the fastest and best ways to help people get back to a full and safe life. Another risk factor for the development of PTSD is poor social support. People are social creatures. We need each other. This is especially true when we're hurt or vulnerable. But it's not enough to just have people around. The quality of the social support matters too. And receiving negative social support when people in your social circle don't believe you, minimize what you've been through, have unrealistic expectations about getting over it, or downplaying your pain, these things can really make things worse. This brings us to our next big idea. Believe people if they share a traumatic experience. As trusted providers, we can be part of the healing social support that people need. If a patient tells you about their trauma, believe them. One of the most powerful things you can do when someone shares a traumatic experience is simply acknowledge it. Phrases like, "I'm sorry that happened to you," or "I believe you," can go a long way in helping someone feel safe and supported. What we want to avoid are questions that sound doubting or judgmental, like, "Were you using drugs at the time?" or "Are you sure that happened?" Even if you don't mean harm, these types of questions can shut someone down and make them feel blamed. An important goal of trauma-informed care is to create space where people feel safe and respected. As part of your work, you might be in the position to ask people about their trauma history. You may have seen the PCL5. It's a PTSD checklist, and it's used for screening or monitoring changes in trauma symptoms. Now, when it comes to trauma, it's important to remember, don't unpack what you don't have the training, time, and space to repack. What does that mean? If you don't have the role, the skills, or the setting to really fully support someone through a deep trauma conversation, it's best not to open up all those details. Asking unnecessary or overly sensitive questions can bring up painful memories without giving the person the support they need to process them safely. And our main goal is to create safety, not undermine it. Instead, focus on what's relevant for the care you're providing in the moment. You can acknowledge their experience, express compassion, and let them know help is available without diving into the entire history. Your job likely isn't to collect every detail of someone's trauma. It's to create safety and trust. Leave the deep unpacking for the settings and providers who can do that safely and with healing purpose. Having said that, it may be part of your job to screen using the PCL5 or other screeners. Any screening about trauma should be done for the patient's benefit. So go ahead and screen for a trauma history. If you've had the training to do it, you have time to follow up, and you have a reason to do so. But we can still use a trauma-informed approach even if we don't know the specifics about someone's trauma history. It's not always right to ask for details. So if you've been trained to ask, you have a reason to ask, you can offer follow-up, and it can help inform treatment or a referral, then we can go ahead. But when should we do it? It's best to do it after some rapport has been built, and it's good to offer a disclaimer or trigger warning, letting people know we're about to ask some sensitive questions. That disclaimer might sound something like this. We know that a lot of people have gone through some difficult experiences, so if it's okay, I'm going to ask you about any difficult experiences that you've been through that might be affecting you today. Is it okay to keep going? You absolutely do not need to answer any of these. We just ask in case it could inform some services that you might want or need. Even after the patient gives permission to proceed, we can still let them know that it's okay to not answer any of our questions or to skip some of our questions. An element of trauma-informed care is being collaborative and respecting patient choices. Using screeners will help us ask relevant questions, using open-ended questions without going into too much depth. Usually the reason that we're using screening tools such as the PCL5 is to understand if a full assessment for PTSD could be useful. So now let's talk more about what PTSD is. PTSD, or post-traumatic stress disorder, is a way to measure and categorize symptoms that can develop in response to trauma. PTSD is a mental health disorder, and we use the DSM-5 to diagnose it. PTSD develops when the emotional responses to a traumatic event continue well after the event is past and impairs functioning. To be diagnosed with PTSD, a clinician uses a client interview, diagnostic questionnaires, and some professional judgment to determine whether the criteria is met for the diagnosis. The first criterion is a traumatic event. The person's directly been exposed to, witnessed, learned about, or had vicarious exposure to perceived or actual situations of death, serious injury, or sexual violence. Something traumatic happened. Now, this criterion for PTSD, according to the DSM, matters most for formal diagnosis or because the definition was used for PTSD in research studies. In practice, there's no need to correct clients about whether the thing they experienced and considered traumatic really fits into the category of criterion A. If your patient says that what they experienced was a traumatic event, we can just believe them. When we talk about PTSD, it helps to know that the symptoms tend to fall into a few main categories. Don't think you have to memorize these in order to be trauma informed. I just want to walk you through them in everyday language so you get a sense of what they look like. First is re-experiencing symptoms. We're looking right now at criterion B. This is called intrusion because unwanted thoughts, emotions, sensations are like an unwelcome intruder in people's minds. This is when the trauma shows up again like it's happening now, even though it's in the past. It might be through nightmares or flashbacks or really strong memories that feel like you're reliving it. Sometimes even small reminders like a sound or a smell can trigger these feelings. The reactions that people have can be emotional, but they can also be physical, a pounding heart, sweating, a sensation like it's happening again right now. Those are intrusion symptoms. Next, criterion C are avoidance symptoms. You might be noticing a theme here about avoidance. This is one of the symptoms of PTSD. Avoidance can feel protective in the moment, but over time it keeps the trauma in place instead of letting healing happen. Next, criterion D are changes in thoughts and mood. Trauma can shape how you see yourself in the world. Some people feel more negative about themselves or they lose trust in others and the world. Some people feel guilt or shame or blame themselves for what happened. It can also cause people to not enjoy pleasurable activities or feel positive emotions anymore. These are changes in thoughts and mood. Next, criterion E are changes in the body and reactions. These symptoms are called hyperarousal and hypervigilance. PTSD affects the nervous system. People might feel jumpy and on edge or have trouble sleeping, or they might get more angry easily. It's like the body stays stuck in high alert even when the danger is over. And as you can imagine, this can cause problems with concentration too, because the brain is always scanning for threats. So to sum it up, PTSD symptoms are grouped into these four categories: re-experiencing, avoidance, changes in thoughts and mood, and changes in physical reactions. Across these dimensions, each individual's experience will look a little different, but understanding the categories helps make sense of what people might be going through if they have developed PTSD after trauma. Trauma-focused talk therapy with a trained therapist can really help people reduce symptoms and heal from PTSD. Trauma therapists have different tools available to treat PTSD depending on the specific modalities they use in therapy. They might use cognitive processing therapy, prolonged exposure therapy, or EMDR. Medication can also help, and a trauma-informed psychiatrist can help someone pick the right medication for them. However, it is important to note that benzodiazepines like Xanax are not an effective medication for PTSD. There are some emerging studies looking at the possibility of treating PTSD with psychedelics, but self-medication is not a safe and effective way for people to treat themselves for PTSD. The National Center for PTSD has a free and helpful decision-making tool to compare the treatments that are available and help people make a choice that fits for them. You can find that tool using the QR code here. Using the DSM and diagnosing PTSD is not the only way that some clinicians think about trauma. Complex PTSD is a diagnosis that's not in the DSM, although it is in the ICD-10. Complex PTSD is usually used to describe trauma that arises from prolonged abuse, like childhood abuse, and causes specific symptoms that are different than the list of symptoms in the DSM and could include emotional dysregulation, really pervasive negative ideas about yourself, and relationship difficulties. Another helpful concept for understanding trauma is the idea of intergenerational trauma. This is not a diagnosis, but it's a helpful way to recognize that traumatic experiences in one generation can impact the health and well being of future generations. Some examples of this are thinking about the legacy of slavery or genocide from one generation to the next. As we discussed, we know that trauma is really common, and many people do have lasting effects from their traumatic experiences. But it's also important to know that most people recover naturally from the traumatic experiences in their life. We call this resilience. Most people who experience a traumatic event don't go on to develop long-term post-traumatic stress disorder. Let's look at some of the ingredients that can contribute to natural recovery from traumatic experiences. Even though traumatic events can overwhelm someone's ability to cope when it happens, research shows that most people actually have a natural ability to heal, and there are three common ingredients that can really help that process along. The first is support from others. Healing happens in connection with others. It helps to know that you're not alone. Having someone you can talk to about what happened, someone who listens without judgment, really makes a big difference. Supportive friends, families, counselors, medical providers that don't minimize what happened and they don't blame you. They just listen with empathy, they validate and believe, and they show that they care. Another ingredient in natural recovery is getting back to life. After trauma, people might find themselves withdrawing from life. They might pull away from people or avoid things that remind them of what happened, but healing is helped by re-engaging in daily life. That means returning to routines at work and school, keeping up with chores and self-care like hygiene, maintaining a healthy sleep schedule. It also means staying connected with safe friends and family. A particularly challenging aspect of recovery is not totally avoiding things that remind you of the trauma because that can actually reinforce the fears. Some people might need the help of a therapist for this. The third is meaning making. Trauma can really shake the way we see ourselves, others, and the world. Part of recovery is finding ways to understand what happened and how it fits into your life story. That might mean noticing when your mind goes to unhelpful places like self-blame and replacing them with more accurate, supportive ones. It might also mean recognizing ways that you coped the best you could and giving yourself credit for the resilience that you showed. Together, these are ingredients that make it more likely that someone develops a natural recovery from their traumatic experiences. Now that we've talked about different aspects of trauma, PTSD, symptoms, and effective treatments, let's get back to the basics. You don't have to be a trauma expert to be trauma informed. We can assume that everyone we meet may have experienced trauma in their lives and bring a trauma-informed principle to all of our patient interactions. So how might a trauma history show up in our patient interactions? Understanding common reactions to trauma can help us recognize that and not take it personally. You've probably heard the phrase fight or flight. Let's learn some more about some of these common responses. When something so frightening happens that it overwhelms one's coping strategies, our brains have a special alarm system that takes over. This is what people mean when they talk about the fight or flight response. It's automatic. This alarm system is run by something called the sympathetic nervous system. This is part of our brain and body's automatic wiring. We don't control it consciously, just like you don't have to think about making your heart beat. When the sympathetic nervous system kicks in, it prepares your body to deal with immediate danger without having to think it through. We've all felt that rush, like adrenaline, whether it's from a real danger or maybe a roller coaster or a Halloween haunted house. It speeds up our heart so our blood moves faster to our muscles. It makes our breathing quicker to get more oxygen. It sharpens our senses, and it can even shut down digestion or memory making in the moment because those aren't needed for survival. These surviving mechanisms are ancient, they're hardwired into us, They're there to increase the chance of us getting through life-threatening situations. So it's great we have them. But sometimes they stay turned on even after the danger has passed, which can be part of why trauma affects people long after it's over. Now, if we don't have a trauma-informed perspective, we might miss the opportunity to recognize a trauma response in our patients. You might have seen some of these descriptions in people's charts before. A patient who's described as aggressive or avoidant, uncooperative, a pushover, defensive. Now, I know you've heard of the fight or flight automatic response, but there's other ways that people might react to trauma as well. And these trauma responses aren't only used when our life is threatened. These reactions might become the main way that someone copes with uncomfortable situations. You might see these kind of responses in a client who's in pain, in an unfamiliar setting, being asked uncomfortable questions, not knowing what to expect, and feeling that things aren't in their control at the moment. In other words, you might see these kind of reactions from a patient you're working with, even though you haven't done anything wrong to harm them. Because we mean well and we only want to be helpful, it can be easy to take these kind of responses personally. Someone in fight mode may seem like they've become angry for no reason or accused us of doing something wrong. Somebody in flight mode might cut an appointment short out of the blue or leave the clinic before the provider even made it into the room. There are two more recognized trauma responses. Some people might become overly agreeable in order to avoid any conflict. This client is fawning. They might agree to whatever you suggest in the moment, but then walk out of the room and toss your treatment plan in the garbage on the way to the parking lot because it was too uncomfortable to tell you that your suggestions were off base. Someone in a freeze response might become totally silent, evasive. They might seem to even float away from the conversation, leaving you with a blank stare. If there's one thing that you remember from this video, it's this. Don't take it personally. We can't know everything that our clients have been through before we meet them. We may not even really understand what they're going through right now. They've developed ways to cope that have become automatic to them. That doesn't mean that people aren't responsible for their behavior or their impact on others around them. But as their medical or behavioral health provider, we can offer patients compassion and understanding, and most of all, not take it personal. One way to know if it's a trauma response that you're seeing is to see if you can help create a space where the person feels more safe, and you might see if the responses subside. Even so, sometimes things can heat up. If that happens, take a moment, calm yourself down first, slow things down, take a deep breath, lower your volume, try not to take it personally. And from there, we can acknowledge, we can validate, we can use our reflective listening skills, we can ask what would be helpful, and we can still trust our gut. This brings us to another important point to end on about minding our own trauma. Before we finish this video today, I want to acknowledge an important element of being trauma-informed providers. Considering that 70% of all people have experienced something traumatic in their lifetime, and that having traumatic experiences might even be the motivator to want to help others, it's also pretty safe to assume that you and your colleagues have maybe experienced trauma. Between the patient's trauma history, potentially your trauma history, maybe even secondary trauma from listening to descriptions of awful things, there might end up being a lot of trauma in the room. And our own trauma can impact how we respond to stress or conflict. So we might need help sometimes. We also need to pay attention to our own self-care. I know everyone says this, but it is important. At work, that might mean making sure that you eat lunch during the day, that you take all of the breaks that you're allowed. Outside of work, it might mean getting enough sleep or de-stressing with regular exercise, making time for friends even when you're busy. And it might also mean caring for your own recovery healing journey with support meetings or therapy. It's important to address too the possibility of violence in the workplace. The environments we work in can really be stressful. Clients might be feeling sick, fearful, uncertain, and vulnerable. There's also a power differential between us as the service providers and those receiving services, and that can really increase patient stress. If a person's response to this stress is a fight response and the situation escalates, there is potential for physical injury or psychological harm. It's really important that if we feel unsafe, that is valid. Excuse ourselves from the room, get help. Our own safety is important too. And just because things escalated doesn't mean we did something wrong. As we come to the conclusion of our video today, let's review our big ideas. The first is that traumatic experiences are so common, we can just safely assume that most of the people we're working with have experienced trauma. We don't need to know the details of it. It can really be part of people's healing to be believed, and we can be part of that for people. So just believe people if they share a traumatic experience with you. We don't need to know the details. In fact, sometimes it's a kindness not to ask for details about people's traumatic experiences. We don't have to unpack anything that we don't have the training, time, and space to repack. When working with people with trauma histories, it can be very important to not take it personally. That helps us respond with our training as well as compassion and care. And our own self-care is valid too. We might have our own trauma that impacts our ability to care for those with trauma. I hope that something from today's video was helpful to you. Thank you for watching this video, and thank you for the work that you do.